Good afternoon, everyone. Thank you for giving us an extra couple of minutes to come back from lunch. We will reconvene the ACIP meeting and begin with our chikungunya vaccine session. I'm going to ask Dr. Beth Bell, who is Workgroup Chair for the Chikungunya Vaccine Workgroup, to provide an introduction and overview for today's session.
Thank you, and hello. Could I have the next slide, please? By way of background, and to refresh the memory of the committee, in February of 2023, FDA accepted Valneva's biologics license application for their chikungunya vaccine and granted priority review with licensure possible in August of 2023. As of yet, there is no chikungunya vaccine that has ever been licensed in the United States or globally, and that therefore there are no existing ACIP chikungunya vaccine recommendations. So the Chikungunya Vaccines Workgroup is in the process of developing policy options for ACIP's consideration for the use of chikungunya vaccine among US persons at risk of chikungunya, including travelers, laboratory workers, and residents of US territories and states with or at risk of transmission. Next, please. Further reminder of a recap of the previous workgroup presentations to the ACIP. In October of 2022, we presented an overview of chikungunya virus disease and vaccines and the immunogenicity and safety of Valneva's chikungunya vaccine. And in February of 2023, we presented the global epidemiology of chikungunya among US travelers, and some additional data about persistent arthralgia following chikungunya. Next. So during today's session, we're going to have 4 presentations. First is a presentation about the value and preferences for chikungunya vaccine among US travelers and healthcare providers, presented by Ms. Nicole Lindsay. Then we'll hear about chikungunya virus infection among laboratory workers from Susan Hills, followed by an update and observations on a large recent chikungunya outbreak in Paraguay, again by Susan Hills, and then Susan will come back for round 3 to provide some information about plans and timelines for workgroup activities going forward. Next, please. Here is our fantastic chikungunya vaccines workgroup. Myself and Wilbur Chen from the ACIP, the CDC lead Susan Hills and Nicole Lindsay, and a number of very much appreciated ex officio ACIP liaisons and invited consultants. Next. And of course, the Chikungunya Vaccines Workgroup CDC participants are shown here on this slide, and we're of course extremely grateful to all of them. Thank you, and I think that's it for me, and we'll turn the floor over to Nicole Lindsay unless you have an objection, Dr. Lee.
Oh, thank you very much. Ms. Lindsay, please go ahead.
Thank you. As Dr. Bell indicated, the work group is currently developing recommendation options for vaccine use among U.S. persons at risk of chikungunya, with travelers being one of the groups we are focusing on initially. We plan to present the evidence to recommendations framework for vaccine use among U.S. travelers to ACIP at the October meeting. As you know, one of the domains of the ETR is the target population perception of the value of vaccination. Therefore, today we would like to present some information on value of a vaccine to prevent chikungunya among travelers. 2 surveys have been conducted to assess the value of the vaccine to prevent travel-related chikungunya among U.S. persons. The first is a survey conducted by the vaccine manufacturer, Valneva, and the second was a survey conducted by CDC. I will start by presenting the findings from the manufacturer's survey. In 2021, Valneva conducted an online survey of 2002 U.S. residents aged 18 and older who either traveled internationally in the last 3 years or planned to do so in the next 3 years. Limited information was provided about the surveyed population, but anyone who identified as anti-vaccination was excluded. Participants were provided basic information about chikungunya disease, including that in rare cases, joint pain and fatigue can last for months or years. No information on risk of infection, potential adverse events, or cost of vaccine were provided. Of the participants, only about 18% had heard of chikungunya prior to the survey. After being provided some basic information about the disease, they were asked 2 questions. First, how likely would you be to ask a healthcare professional about a vaccine to protect yourself against chikungunya? 72% of respondents said they were very or somewhat likely to ask. Next, they were asked, if a doctor or healthcare provider recommended the chikungunya vaccine for you, how likely would you be to get vaccinated? 81% responded that they were very or somewhat likely to be vaccinated if recommended. In summary, awareness of chikungunya was low among this traveler population. However, following a description of the disease, most would be likely to ask a healthcare provider about a vaccine and would be likely to be vaccinated if recommended by their provider. The limitations of the survey were that no information was provided to participants about the risk of disease or risks and benefits of vaccination. Also, no information was provided about vaccine cost, which can be substantial. Finally, although this group did include international travelers, we don't know how representative they might be of the traveler populations to areas at risk of chikungunya. Now I'm going to review additional data collected by CDC on the potential value of a chikungunya vaccine among U.S. persons. This survey was conducted by a company called Porter Novelli, which runs several surveys throughout the year. The consumer style surveys are targeted to a panel of participants representative of the non-institutionalized U.S. population. Panel members are randomly recruited by mail using probability-based sampling. Mail is used so people can be included whether or not they have phone or internet access. Participants are provided with laptops and internet if needed and receive small monetary rewards for completing surveys. For this particular survey, conducted in the summer of 2022, about 6,000 adults were asked to participate, and 4,156, or 69%, completed the survey. The survey includes core questions to capture demographic information and then a number of questions related to consumer attitudes, values, and behaviors in a variety of areas. The resulting data are weighted to the U.S. population for a number of variables that are listed here on the slide. There were 3 chikungunya-related questions included among the multiple questions on the survey. The first was, imagine you are going on a trip to another country. You have a 1 in 150 chance of getting a disease. About 1 in 4 people who get this disease suffer from long-term joint pain. A vaccine is available that costs $350 and is not covered by insurance. How likely would you be to get the vaccine? The second question posed the same scenario, except with a lower risk of infection of 1 in 15,000. These risks were based on very rough estimates of travelers of risk during an outbreak and background risk at other times. The vaccine price was an estimate based on an average price for a travel vaccine in the United States. The third question asked what factors were most important to the respondent in deciding whether or not to get the vaccine. This slide summarizes the demographics of the survey participants. There was an even distribution among the sexes. All participants were adults with a median age of 54 years. The majority, 72%, identified as white non-Hispanic. 5% had less than a high school education, 25% high school education, and 70% had at least some higher education. 10% reported less than $25,000 annual household income, 30% were between $25,000 and $75,000, and 60% had annual income of $75,000 or higher. Here are the overall results for the first question, asking about likelihood of vaccination in a high-risk outbreak scenario with responses on a Likert scale. 42% said they were somewhat or very likely to be vaccinated, 26% were unsure, and 32% were somewhat or very unlikely to be vaccinated. The next few slides show results by demographics. On each slide, each row represents a specific group for the demographic category under consideration. The colors along each row represent the percentage of subjects likely in green, unsure in gray, or unlikely in blue to be vaccinated. Overall, 35% of the 18 to 29-year-olds were likely to be vaccinated, which was lower than that among the older age groups, where 43 to 45% in each group were likely to be vaccinated. Here are the responses by sex. 44% of males and 39% of females were likely to be vaccinated. Females were less likely to be vaccinated and more often unsure of whether they would choose vaccination. For both sexes, about a third were unlikely to get vaccinated. Here are the responses by race, ethnicity. Overall, 42% of whites, 36% of blacks, 42% of Hispanics, and 51% of others were likely to be vaccinated. So there were some differences, but determining how meaningful these differences are is difficult, particularly since we do not really know what the other category represents. The key difference that did not involve the other category was that blacks were less likely to be vaccinated and more likely to report unsure than all other categories of race ethnicity. So this slide shows likelihood of vaccination by education level, comparing those with high school education or less, those with some college, and those with college education and higher. We see a trend of increasing likelihood of vaccination with increasing education. 31% of those with high school education or less were likely to be vaccinated, compared to 54% of those with college or higher. This slide shows likelihood of vaccination by household income, where again, we see a trend of increasing likelihood of vaccination with increasing income. 22% of those in the lowest income level were likely to be vaccinated, compared to 51% of those with household income of $75,000 and higher. Overall, 42% of respondents were likely to be vaccinated when disease risk is high. About a third were unlikely to be vaccinated, even in a high-risk scenario, and about a quarter were unsure. These findings were fairly consistent by sex, but there were a few differences among demographic groups that seemed meaningful. There was a lower likelihood of vaccination among youngest age groups and those with lower education and household income levels. And blacks were less likely to be vaccinated and more likely to be unsure about vaccination than other race and ethnicity groups. Here are the overall results for the second question, where we asked about the likelihood of vaccination in a lower risk scenario of 1 in 15,000. Here, 27% said they were likely to get vaccinated, 24% were unsure, and almost half were unlikely to be vaccinated. This question highlighted that the level of risk is an important factor in determining likelihood of vaccination. Again, 27% reported they were likely to be vaccinated in the low-risk scenario, compared to 42% in the higher-risk scenario. Still, about a quarter of respondents were unsure, which is a fairly significant proportion. In the interest of time, I'm not showing the data here, but there were similar trends for demographic factors between the high and low-risk scenarios, with responses leaning more towards the unlikely end of the scale, where risk was lower. The last question of the survey asked what factors were most important in deciding whether or not to get vaccine. Respondents could select all of these provided responses that applied to them. The most commonly selected factor was chance of getting the disease at 57%, which is consistent with our findings for the high and low risk scenario questions. Also important to many respondents were chance of vaccine side effects and vaccine cost. Just over a third responded that the chance of getting long-term joint pain following infection was important. 6% reported that they do not ever get vaccinations. We also looked at these responses by demographic factors. In the interest of time, I'll not be presenting the data, but we'll just summarize the findings briefly. We didn't see many differences by age, although the youngest age group was more concerned about costs and less about long-term joint pain than the other age groups. It was also interesting that the middle-aged, those aged 45 to 59, were most concerned about vaccine side effects. We didn't really see meaningful differences by sex or race ethnicity. The importance of risk of disease and risk of long-term joint pain following infection increased with both education level and household income. Conversely, the proportion of respondents that do not ever receive vaccinations decreased with increasing education and income. We looked at these factors influencing vaccination among those likely and unlikely to be vaccinated in both the high and low risk scenarios. This slide shows the results for the higher risk scenario. The factors influencing decision-making are listed along the bottom. The percentage of persons for whom the factor was influential is shown in blue for those likely to be vaccinated and in orange for those unlikely to be vaccinated. Perhaps as expected, those who are likely to be vaccinated more often reported that risk of disease and long-term pain were important than those unlikely to be vaccinated. The unlikely group more often reported that costs and that they do not get vaccinations as important factors. It was interesting that the two groups were similarly concerned about risk of vaccine side effects, about 40%. If we look at responses for the lower risk scenario, they are quite similar to those in the higher risk scenario, although there is a smaller difference between the groups in the chance of getting disease being an influential factor. In summary, the most commonly reported factor considered in making vaccination decisions for chikungunya was the risk of getting the disease, which is consistent with the findings for our high and low risk scenario questions. Also important were the risk of side effects, vaccine costs, and the risk of long-term joint pain following infection. There were significant differences between those likely and not likely to be vaccinated in importance of these factors, with the exception of concern about side effects. For the likely to be vaccinated group, key influential factors were chance of disease and chance of long-term joint pain, while for those unlikely to be vaccinated, key factors were vaccine cost and chance of disease. There were multiple limitations of this survey. The primary limitation is that these respondents are from the general U.S. population, and we don't know how well these responses would reflect the attitudes of a traveler population. Respondents were given very basic scenarios about the disease. More detailed information might affect attitudes about the value of vaccination. In addition, no information was provided on the likelihood or type of side effects from vaccination. Finally, the vaccine cost was an estimate based on that for a typical travel vaccine and not the actual cost. In summary, in this survey, we found that among a general U.S. population, 42% of respondents were likely to be vaccinated when disease risk is high, 27% when disease risk is low. About a quarter of participants were unsure in both scenarios. These are lower values than reported in Valneva's survey, where 81% of subjects were likely to be vaccinated. But there were important differences in the survey methodologies, including their use of a traveler population compared to our general U.S. population, and their inclusion of comprehensive background information on the disease compared with a focus on disease risks, sequelae, and costs in the CDC survey. Also, the framing of the question, likelihood if recommended by a provider versus likelihood of vaccination, might also have been an important difference. Finally, I'll briefly present some information on an additional survey Valneva conducted looking at the awareness of chikungunya and value of a chikungunya vaccine to U.S. travel healthcare providers. In 2021, an online survey was conducted among 158 U.S. travel healthcare providers who routinely perform pre-travel health counseling and prescribe and/or administer relevant travel vaccines. The participants were a mixture of healthcare provider types, including physicians, nurses, and pharmacists, and worked in a variety of practice settings relevant to travel health. Participants were first asked how familiar they were with chikungunya disease. Only 30% reported that they were familiar with chikungunya and had clinical knowledge of the disease. 20% said they had heard of chikungunya, but didn't really know what it was. The majority, 51%, were not familiar with chikungunya at all. Following the first question to gauge knowledge, participants were provided some information on the disease, including its epidemiology, clinical presentation, and the types and duration of sequelae. In addition, they were told that chikungunya vaccines were likely to be available within a few years. Then they were asked to indicate their likelihood to recommend or prescribe a chikungunya vaccine if recommended by ACIP. 15% reported that they were very likely, and another 73% were somewhat likely to recommend vaccination. Just to summarize, there was a low awareness of chikungunya among these U.S. healthcare providers, even though they work in travel medicine. Following minimal education about the disease, most providers surveyed would be likely to recommend or administer a chikungunya vaccine to travelers if recommended by ACIP. It was, however, explicit in the question that vaccination would be recommended by ACIP, and the healthcare providers were not given estimates of disease risk or possible risks associated with vaccination. To summarize everything I've presented today, awareness of chikungunya is low among both travelers and healthcare providers. Healthcare providers would be likely to recommend vaccination as recommended by ACIP, and travelers are interested in vaccination if recommended by healthcare providers. Independent of a healthcare provider recommendation, about 30 to 40% of U.S. persons indicated interest in vaccination, and the remainder were unsure or unlikely to be vaccinated. There was clear variability in the population's perception of whether the potential desirable effects of vaccination outweighed the undesirable effects. Risk of disease, vaccine cost, vaccine side effects, and risk of chronic arthralgia are influential factors in individuals deciding on chikungunya vaccination. So I'll turn back to Dr. Lee.
Thank you very much. And this presentation is now open for questions. Dr. Brooks.
Just one quick comment for those who said that they would not get any vaccines. I don't know how it would remove them from the equation, but therefore I don't think they gave relevant information other than they just would be those that wouldn't get vaccinated. You see what I mean?
I'm sorry, I had a little trouble hearing you.
Oh, okay. There was a subset, was a group of those that said they would not get any vaccine. So I don't know how to exactly include that in terms of my perception of how you interpret the information of the public, because theirs was a very general statement versus specific to the condition. That's all.
Yeah, understood and appreciate that comment. It was a pretty small proportion of the overall respondents, so we hope that doesn't influence the results too substantially.
Thank you. Any additional questions? also happy to open to our liaisons if any questions. Okay, I don't see any hands raised, so we'll move on to Dr. Susan Hills. And Dr. Hills, you have the next 3 presentations, so why don't you tell us when you'd like to pause and take any questions or comments, okay?
Thank you, Dr. Lee. So at the October ACIP meeting, in addition to presenting the ETR for use of chikungunya vaccine among travellers, we'll be presenting the ETR for chikungunya vaccine use among US laboratory workers. The workgroup hasn't yet presented any information to ACIP on this topic, so today I'll provide a summary of chikungunya virus infections among laboratory workers. So in the laboratory, chikungunya virus is generally handled at a biosafety level 3. One particular issue in regards to chikungunya virus is that there can be high viral loads in acute blood samples from infected patients, and so this increases the risk for laboratory-acquired infections. Most data on laboratory worker infections come from a 1980 summary article by the Subcommittee on Arbovirus Laboratory Safety, or SALS. For the more recent period, there is at least one case report in a general publication on laboratory exposures in a US facility, and a small number of cases has been reported to the US National Arboviral Disease Surveillance System. In the late 1970s, SALS conducted a literature review and 2 surveys to gather data on laboratory-acquired infections. An initial survey was sent out to national and international laboratories in 1976 and then sent again in 1978 to reach some additional labs and to gather data on incidents that occurred in the intervening period. From the SALS report, 39 chikungunya virus disease cases or infections were identified. Among these, 38 or 97% were disease cases and no deaths were reported among these cases. One case was a person with an asymptomatic infection. These data suggest that if an exposure occurs that leads to infection, the likelihood of developing symptomatic disease rather than experiencing an asymptomatic infection might be high, which also reflects a high symptomatic to asymptomatic ratio for mosquito-borne chikungunya virus disease cases. Among the 18% of reports for which the route of exposure was described, all were due to aerosolization of virus. One disease case was described briefly in a publication on the experience of one US laboratory with exposures to a variety of infectious pathogens. The chikungunya case occurred sometime during the period of the overall report, which covered 1989 to 2002, but the specific year for the case was not available. The mode of transmission was through a needle stick injury, and no additional details about the exposure were provided. Although the person fully recovered, they had a slow convalescence with intermittent joint pains, headaches, and blurred vision for several months after infection. Chikungunya became a notifiable disease in 2015, and cases have been reported to the National Arboviral Disease Surveillance System since that time. Of note, disease cases, but not asymptomatic infections, can be reported through this system. There were 4 disease cases among US laboratory workers notified in the 8-year period from 2015 through 2022. One case was hospitalised for observation, but otherwise no hospitalisations or deaths were reported. The route of transmission was known for 3 of the cases. For 2, a needle stick injury occurred while the researchers were working with and injecting mice. And for the 3rd case, a researcher experienced a forceps prick while dissecting mosquitoes infected with chikungunya virus. There is a high likelihood that the cases I've just described underrepresent all infections in laboratory workers. Disease cases are likely underreported to the National Arboviral Disease Surveillance System, and as I noted, asymptomatic infections are not reportable through this system. There is no formal laboratory event-related surveillance system for reporting these type of events. In addition, there might be a reluctance for authors to publish if an infection was acquired in the laboratory where they were working. So in summary, laboratory workers that are at risk for chikungunya virus infections and disease, and at least 44 infections and disease cases have been reported, including 4 cases during the last 8 years. Among the cases and infections, the documented modes of transmission have been through the aerosol or percutaneous routes. And finally, it appears that the likelihood of developing symptomatic disease rather than asymptomatic infection is high. So thank you. And I will hand back to you, Dr. Lee, for questions at this point because the next topic is unrelated.
Of course, thank you. This presentation is now open for questions. Ms. Bata?
I'm trying to understand the context of these reportable cases and the rarity of it, or should we not expect any? Can you describe, is this very small number, or should we be worried about this number?
So I think this needs to be interpreted in the context of the small number of laboratories that might be working with chikungunya virus for research purposes. We actually don't have a specific number. There's no way to document that, but I suspect the number of laboratories working with chikungunya virus is relatively small. I think there is likely to be underreporting. So one disease case every 2 years reported is not insignificant, particularly if given we know there is a concern about 1 in 4 people have chronic arthralgia after chikungunya. And the third issue is that I guess earlier when the SALS report was done, that there was sort of active efforts to identify the infections, and that did pick up a lot of infections. I think, clearly laboratory standards have improved and safety has probably improved over time. So I think, clearly it's not a frequent event, but I think it's significant enough that there is a concern about these laboratory workers, and that, in consideration of there being a vaccine, we need to consider about protecting them. We do have one initiative underway with the American College of Arbovirus and Virology to actually actively reach out to laboratories that might be working and try and get a better understanding if there is more infection. So I think it's uncommon, but in the context of how frequently chikungunya might be handled, I think it's probably important. In fact, this was listed as a BSL-3 agent because of the concern of the number of events that were reported in the SALS survey.
Thank you. Dr. Paling?
So thank you for putting that in a very important context for us. And could you remind me, how often could I get chikungunya and be asymptomatic or mildly symptomatic?
Mm-hmm. So interestingly, given it's an arboviral disease, there's actually a high symptomatic to asymptomatic ratio. From studies that have been done, about 72 to 97% of people who do get infected do get symptomatic disease. So it's a smaller proportion of people that get asymptomatic infection.
Thank you. Dr. Sanchez?
Thank you. I just had a question in terms of the transmission, and just correct me or enlighten me, in terms of aerosol, is this from like a blood spill, or, because I mean, these patients don't go on their standard precautions.
Yeah, unfortunately there was no additional data that were provided in the survey, so we don't have any additional information for the context of these particular infections. We do know for other laboratory infections with arbovirus that it's working with the virus in the laboratory. For example, there was, with Zika infections, there was somebody who was doing neutralising antibody testing that requires a live virus, and they were infected somehow in that process. There was somebody working outside a hood. So yes, they should be using standard precautions, but these events, are occasionally occurring.
Thank you. I don't see any additional hands raised, so why don't we move on to the next presentation? This is update and observations on a large chikungunya outbreak in Paraguay.
Thanks, Dr. Lee. So the objective of this presentation on the very extensive chikungunya outbreak in Paraguay is to help provide some context on why a chikungunya vaccine has been developed and describe some features of the outbreak that I think are noteworthy in relation to vaccine recommendations. So prior to 2022, Paraguay had reported 2 small, fairly localised outbreaks of chikungunya in 2015 and 2018. Beginning in October 2022, an increase in cases was again noted. From October 2022 through June the 3rd, 2023, over 167,000 chikungunya cases were notified to the Paraguayan Ministry of Health. Based on these cases, the cumulative national incidence was about 22 cases per 1,000 population, reaching about 55 cases per 1,000 population in the capital Asuncion and the neighbouring Central Department. The epidemic reached a peak in week 6 of 2023, plateaued for several weeks, and case numbers began to decrease in about week 13 of 2023. Currently, about 1,500 cases are being notified weekly. The number of cases by district during 2023 are shown on this map of Paraguay. The outbreak was initially focused in Asuncion and the surrounding Central Department in the central west part of the country, but subsequently spread to outlying areas, and cases have now been reported from almost all districts of Paraguay, including most of the districts along Paraguay's borders with Brazil, Argentina and Bolivia. Among probable and confirmed cases, there have been about 8,600 hospitalisations, which is about 9% of all about 91,000 probable and confirmed cases. And 263 persons have died, resulting in a case fatality rate lower than 1%. In addition to Paraguay experiencing a large outbreak, there has been an increase in chikungunya cases in other areas of South America during 2023, and also transmission in new areas. For example, local transmission of chikungunya virus was reported for the first time ever in Uruguay beginning in April this year. Although Argentina and Brazil have previously reported chikungunya cases, spread to areas outside historical transmission areas has also occurred this year in these countries. Data for US travellers for 2023 reported to the US National Arboviral Disease Surveillance System are still preliminary, but cases among US travellers to Paraguay, Uruguay and Argentina have been reported this year. Now I'd like to describe several observations on the outbreak that I think are noteworthy in relation to vaccination recommendations. The first point is how rapidly the outbreak evolved and how large it became in a short period of time. I discussed at the February meeting how outbreaks can be explosive and involve large percentages of the population in a short period of time, and that has been clearly demonstrated in Paraguay. After the outbreak was recognised in October, case numbers gradually increased, with fewer than 10,000 cases reported by the end of 2022. But from the first week of 2023, there was a steep increase in case numbers, and by week 6 of 2023, more than 50,000 cases had been notified. Secondly, although the overall hospitalisation rate has been less than 10%, and the case fatality rate is very low at less than 1%, there is clear variation in rates of severe disease by age group, with severe outcomes a concern for both young infants and older persons. This graph shows the number of hospitalisations and case fatality rates among probable and confirmed cases by age group as of March the 11th, 2023. Hospitalisations are shown as the blue bars, and you can see that there is a preponderance of hospitalised cases in the older age groups, with 41% of all hospitalised cases in persons aged 60 years and older. The case fatality rate is shown by the dark blue line, and you can see the higher case fatality rates in infants under 1 year of age, especially neonates or those under 1 month old, as well as in the older age groups. Overall, about 3/4 of all patients who have died during the outbreak have had underlying medical conditions. Specifically, in deaths among those 60 years and older, about 70% had cardiovascular disease, about 40% had diabetes, and about 60% had 2 or more comorbidities. The highest case fatality rate among any age group during the outbreak has been a rate of 4% among neonates. If a pregnant woman is infected at the time of delivery, intrapartum transmission to her newborn can occur in up to 50% of cases. Severe disease in the newborn often follows, with presentations including encephalitis, shock, or hemorrhagic manifestations, and management in intensive care with ventilation is often required. Finally, the impact of the outbreak on health services has been very apparent. Several hospitals reported that there were substantial challenges in dealing with patient loads, with about 30% of daily hospital outpatient visits attributable to patients seeking care for chikungunya for most of the outbreak period. In addition, hospital employees were also frequently infected, with one hospital reporting up to 10% of staff absent on any given day, either because of acute infection or because they needed time to convalesce because of ongoing joint pain. So in summary, the observations from this outbreak are that it has been explosive, similar to many previous chikungunya outbreaks, and has also been extensive, with transmission throughout most of the country. It has reinforced that groups at risk for severe disease include infants, older adults, and persons with comorbidities, with neonates at highest risk of death. And finally, it has had a huge impact on health services in terms of treatment of sick patients and absenteeism because of ill staff. And Dr. Lee, I'll again hand back to you for any questions before I give my final presentation.
Thank you. This presentation is now open for questions, and you're definitely painting a significant picture for us here. I don't see any hands raised either in the room or on chat. Okay, you've made the case for the burden. So would you like to go on to the work group plans and timelines?
Yeah, thank you, Dr. Lee. So I'll conclude this session by just briefly reviewing the work group plans and timelines. Licensure of Valneva's chikungunya vaccine is possible in August 2023. The workgroup plans to present the evidence to recommendations frameworks for travellers and laboratory workers and draft recommendations for ACIP's consideration at the October 2023 ACIP meeting, with a vote at the February 2024 meeting. We will then be continuing with our discussions to consider recommendations for adults living in US territories and also US states at risk for outbreaks. In addition to further presentations to ACIP on topics relevant to consideration of vaccine use in persons in US territories and states with risk of transmission, we anticipate that over time there will be additional data on the use of Valneva's vaccine among younger age groups, and there might be additional chikungunya vaccines submitted for licensure in the United States. We will be presenting those data as they become available. And to conclude, I'd like to acknowledge the hard work of the Chikungunya Vaccines Workgroup members, and I thank you all very much for your attention. Thank you, Dr. Lee.
Thank you, Dr. Hills. I'm going to open it up to ask if there's any additional feedback or information members would like to give, given the timeline ahead and just making sure the work group has the information it needs from the committee. Dr. Chen.
I thought I'd just make a couple comments, and thank you, Susan, for a great presentation and for the CDC contributors to put all this information together. I'm going to also lump my comment with also dengue as well. So, you know, we're talking about mosquito-borne diseases. They may not be so important, you know, for continental U.S., but certainly important for our U.S. territories. and affiliated states. And, it's also of global importance as well. The travelers market is a narrow market, but we are seeing, that these are unpredictable, that they are rapid in their epidemic outbreaks. And so again, even as a traveler, it's very uncertain as a risk, but it's something that can be predicted to a certain extent. Shortly before travel, we see significant risk for some lab workers who are working with these BSL-3 agents. So having these vaccines available is important, and for us to kind of carefully think about these recommendations. As we gain more experience with these vaccines, I think it'll be informative, because we don't know if, we have these mosquitoes on our shores, so we just don't have the endemic disease in the mosquitoes in the continental U.S., but it could be in the future that we see more and more of these sporadically outbreak in the southern areas of the continental U.S. So again, just kind of raising awareness of this, but it is a global problem as well. So please help us to give us some feedback as we think through these recommendations, so that we can come up with good presentations for you in October. Thanks.
Thank you. Oh, Dr. Romero? Oh, okay, we're going to go to Dr. Sanchez and Dr. Romero.
No, I just wanted to comment. So this is a live attenuated vaccine, and the mortality in neonates is amazing. And so it's not going to be a recommendation for pregnancy, and has not been transmitted, as far as I know, through human milk, through breast milk. And so I just think it's going to be important for travelers, especially women who may be getting pregnant during the time that they're traveling. I think it's going to be really important to bring that up in the discussions as well.
Dr. Romero? Oh, sorry.
Just respond. Thank you for that important comment. As you mentioned, it is a live attenuated vaccine, and the work group has just started discussing the issue of use in pregnancy, given the concern about this intrapartum transmission. But of course, as you said, live attenuated vaccines are typically contraindicated during pregnancy. There are no clinical trial data essentially for this vaccine for use in pregnancy. There is not a specific concern about vertical transmission of live chikungunya virus from the mother earlier during the pregnancy. It's really sort of the end of the pregnancy, intrapartum, but there has been a few events where vertical transmission, intrauterine transmission has occurred, so it's a complex issue, and we are just sort of trying to discuss that, to think about, the concern, as you mentioned, about the infants and intrapartum transmission, but the issue of it being a live attenuated vaccine.
Do you know if the company has evaluated that at all in animals? Has the vaccine been evaluated in pregnant animals, whatever the model may be?
Sorry, I was having trouble hearing the question, but yeah, there has been mouse data, if I recall, that showed no concern. There is Valneva staff on the line that may be able to comment additionally on that.
Yeah, and my recollection was limited animal toxicology. This is a vaccine that is being evaluated on the basis of the animal rule with the FDA. We won't have human vaccine efficacy data for the basis of licensure for this vaccine, so we won't be presenting that. Takeda won't be presenting that, just to remind you.
Dr. Romero?
I was just going to add some color commentary to what Dr. Chen said, that just wanted to remind everybody that it is a potential threat globally and in the United States due to climate change. And so introduction of the vector, and as our seasonal and summer patterns change, this could become more of a threat to the United States.
Yeah, I actually, I really appreciate that point, Dr. Romero, and Dr. Chen mentioned this. It applies to mosquito-borne illness. Although we're looking at it by vaccine, it may be worth gaining a better understanding as a committee as sort of everyone is starting to embrace, I hope, the field of sustainability and the work that's ahead for all of us. Recognizing that it's a global issue, but it's also a local issue will be important. So wondering, as much as we have started to think about a respiratory disease platform, if we should be thinking about not travel vaccines per se, but really just looking ahead to the changing epidemiology, because it does affect the Americas and will continue to become a greater and greater burden. So great if we can think about prevention early. Dr. Cotton?
And thank you for that comment. There's definitely been these viruses seen in places like the south of France where they weren't previously endemic. I guess I would just put a plug out for the immunocompromised patients. These are live attenuated vaccines, and so they won't be a good alternative for them. So if companies and others developing new viruses could think about non-live viral vaccines, that would be appreciated. Thank you.
Thank you, Dr. Cotton. Anything else? Okay. Thank you. With that, we will thank our speakers from the Chikungunya session and take a break. We're going to take a 10-minute break and convene at 50 minutes after the hour to start our last session on RSV vaccines. Thank you.